So welcome to today's webinar, Medicaid Managed Care, the Provider Impact. Presenting today, we have Cassidy Carmody from the Institute on Public Policy for People with Disabilities, Linda Timmons from Mosaic, and myself, Carly Friedman from CQL, the Council on Quality and Leadership. Today we'll be discussing an overview of Medicaid managed care, including different service delivery models and a national outlook on managed care for people with intellectual and developmental disabilities, or IDD. The webinar then highlights the perspective of human service providers and features one large agency's experiences with managed care. The webinar also offers guidance regarding quality and value-based service provision. Just a little housekeeping, as Megan mentioned, the webinar is being recorded and will be available on our website for you to reference at a later time, so no need to take vigorous notes if you don't want to. I will be taking questions at the end of the webinar as time permits, and if you have any technical issues, you can enter those questions into the Q&A box and we'll help sort those out. So I'm going to turn it over to Kathy Carmody now.
Thanks, Carly. Good morning, everyone. Carly, we can...
There you go.
I've only seen two, but
Yeah, we can go to that slide. So I'm happy to be joining you today. Before we briefly explore some of the emerging payer and business models in IDD services across the country, I think it's helpful to review the payer model that new approaches are a departure from. So we can go ahead on the screen and put up all of my bullet points for this slide, if you will. Typically, IDD Medicaid-funded services have been delivered in a fee-for-service arrangement. In a fee-for-service arrangement, or FF payer arrangement, reimbursement is based on units of service, such as an hour, night of care, or visit. In this model, the value or outcome yielded by the service isn't considered, and the incentive is for volume over value. Consider, for example, a system where a person with IDD can access up to a certain number of hours of a service type, say therapy services, over the course of the year. Strictly from a payment perspective, the incentive here is to provide the maximum number of hours of service in a year, rather than services that yield a desired outcome in a shorter period of time. The latter arrangement is often called pay for performance or value-based payments, where the incentive is to maximize outcomes versus service units. In a pay for performance or value-based payer arrangement, the provider would receive some level of reimbursement for delivering desired outcomes rather than just units of service. Payers, meaning states and CMS, are increasingly looking to alternatives to a fee-for-service payment model for physical health services, as well as long-term services and supports for other populations, such as elders or people with physical disabilities. Today, we'll be talking about some of the ways this approach is impacting IDD services and systems across the country. We can go to the next slide. So why do states want to, quote unquote, manage long-term services and supports? You see on the screen some of the factors that contribute to states' interest in wanting to manage these services, which we refer to as LTSS. Some of the considerations that states make have to do with payment issues and where money is going, so deflecting payment from institutional services to home and community-based services, improving the experience of people, their quality of life and outcomes, reducing waiting lists, improving access to care, and increasing budget predictability and managing costs. I think many, we're going to stay on that screen. I think many IDD organizations have a healthy dose of trepidation regarding the advancement of managed care initiatives into the IDD space. But looking at the goals states are seeking to accomplish, they generally align with those that most advocates support. Assuring that these goals remain central and that the process for achieving them is guided by agreed upon principles, such as quality and access improvement, as well as strong stakeholder engagement, is essential. One of the items I want to point out on this screen is the lack of consistency of quality measures across state HCBS systems. While states have to identify quality measures in their waiver applications, they vary from state to state and may be more process-oriented, such as timeliness of service planning or monitoring visits, rather than outcome-oriented. We'll talk about some emerging efforts in this area later in the webinar. So on the next slide, we take a look at how does managed LTSS work? The term managed care tends to conjure up a fairly rigid and prescribed framework for many of us, but in fact, There are a variety of ways states approach alternatives to the traditional fee-for-service payment model. A few considerations in this area are highlighted on this slide. While a model similar to how managed care is coordinated in the physical health space is among the options that states consider, such as reliance on a commercial insurance company, there are other approaches that states leverage. There are other approaches that leverage the experience, expertise, and orientation of existing provider organizations to carry out a broader role in "quote unquote" managing the delivery of long-term services and supports, as well as public-private partnerships that remove a profit incentive from the equation that are being adopted in other states. We can go on. So where are IDD services in an MLTSS arrangement? This helpful map from our friends at Anchor shows managed care penetration for people with IDD across the country. The continuum starts with the white states, where no aspect of healthcare or LTSS is in a managed care system, progressing to the dark states, where LTSS is in a variety of different managed care arrangements. Within those states that do have managed long-term services and supports, or MLTSS, there are different frameworks in place, from Iowa and Kansas, where the system more closely aligns with what many of us think of as a traditional managed care model with heavy involvement of insurance companies, to Arizona, where the state oversees the managed care system, and Michigan and Wisconsin, where regional quasi-public-private entities oversee services. On the next slide, we'll talk about some of the reasons that IDD services are slower to move into a managed care payment model than other populations or service lines. Some of the concern expressed by stakeholders and advocates, including the lack of potential cost savings, include the lack of potential cost savings. Many providers would argue that their rates are already insufficient and fear that further reduction in a managed care arrangement in order to generate profit would be inevitable. What we hear from many funders of managed care models is that within the MLTSS system for IDD services, where savings tend to be generated are on the physical healthcare side, so that it's rather than reducing rates and payments to community agencies that provide services, there's better coordination of primary healthcare services that is able to keep people out of more costly inpatient services. Another distinction within the IDD system is that the providers of service tend to be smaller, more independent, and less technologically sophisticated than many other organizations in the healthcare arena. Think about how interconnected hospitals, physician practices, outpatient clinics, and pharmacies have become in the past decade. IDD providers tend to be much more siloed than other parts of the service delivery system. While IDD services are distinct from physical health services, it's important to remember that we are primarily paid for through a health insurance program. And so I think it's important to know what's happening elsewhere in the healthcare arena when considering what might lie ahead for IDD services. We can go to the next slide.
Coming over the speakers, but I need
While no two systems are identical, there are some features of a managed MLTSS system that you commonly see regardless of what entity. Oh, I'm sorry, we can go to the next slide. So there are some common features regardless of which entity might be managing the care. First, unlike the traditional fee-for-service system, the state doesn't contract directly with provider organizations, unless the state itself is acting as a managed care entity, but rather contracts with managed care organizations directly, which in turn contract with providers of service. Unlike the traditional Medicaid system, MCOs do not have to contract with every willing provider that meets the state criteria. Rather, the MCO can selectively choose which organization to contract with for services. While network adequacy is always a consideration, this doesn't necessarily translate into contracts with every existing provider once the state adopts a managed care approach. States typically issue an RFP for MCO vendors that defines the requirements the managed care organizations must meet. It's essential for stakeholders to be part of defining the RFP details so that bidders are responsive to our priorities and concerns. And another consideration is that provider organizations may have multiple MCO contracts, which, while expanding opportunities for serving people, can be challenging if each of those MCOs has their own unique contractual requirements. Unlike the state, which has a single process and protocol for engaging with contractors, Individual MCOs can each have their own unique billing requirements and procedures for a variety of processes. This means that provider organizations may need to adapt their internal operations to accommodate several different sets of procedures, which of course can be challenging. One example of the variability among MCOs is in the area of service authorization. MCOs may have different requirements for receiving authorization to provide a designated service, and they have different caps on the amount, duration, and intensity of services that can be provided. Provider organizations need to stay on top of these requirements, or they may find themselves in the position of rendering a service that wasn't properly approved, which causes obvious billing implications. So this slide shows some of the alternatives to the fee-for-service model that are emerging in other sectors of the healthcare industry and among other populations within LTSS. While we haven't seen widespread adoption of these arrangements within IDD services, there's an increasing discussion about how they might be adapted to our system. I'll just talk a little bit about a pay-for-performance or a value-based model in which there is identified some measurable outcome or indicator that the service has to meet or demonstrate. The clearest example of this in IDD services would be in the area of employment. Under a fee-for-service payer arrangement, an organization would receive a set payment to try and support a person to obtain and maintain employment, regardless of whether the service provided actually achieved the employment outcome. In a pay-for-performance or value-based payment model, there would be a financial incentive for achieving the employment outcome that would not be provided if the service wasn't successful in achieving that result. Another example is an arrangement whereby a provider receives an enhanced payment for positive customer ratings regarding service delivery. So those are just a few examples of some alternate payment models. We can go to the next slide. So this slide highlights some things that IDD provider organizations can do to explore and prepare for alternate payment models, none of which I think are in any way detrimental to an organization's existing service delivery. For example, being able to quantify the outcomes your services help people achieve is important regardless of who's paying you. A really important takeaway is the first bullet point. The IDD world and managed care worlds are quite different. We have to better understand the language, value, culture, and rules of the managed care world in order to successfully navigate it. Some of the other areas that IDD organizations can be looking at include the strength and focus of their data collection systems and how the information yielded by those systems is used to inform organizational decision-making and measure critical outcomes. Another consideration is the capacity of an organization's technology infrastructure and whether it can absorb more sophisticated and diverse functions that could be required in an alternate payment model, such as interfacing with multiple payers and meeting their unique billing requirements, cross-referencing service authorization parameters with service delivery, and generating performance measure data to demonstrate attainment of contractual outcomes. The final slide in my part of this presentation is just a takeaway thought and really the focus of much of our work at this point. We can go on to the next slide. While we as IDD providers may have well-founded concerns about emerging funding models, we need to understand and consider which models and or features we think would be best suited or least suited for people with IDD and the services we provide so that we can be as influential and impactful as possible in shaping the future. Or to put another way, if you're not at the table, you could be on the menu. We think it's important for folks to understand some of the parameters and options and be processing that and thinking about how we can help shape the future for our service delivery system. And now I'll hand the screen over to Linda Timmons, who will share some perspective as CEO of Mosaic.
Thanks, Kathy, and thanks for your great overview of managed care and what we think is headed our way. And thanks to CQO for hosting this webinar on an important topic as we talk about quality and managed care. So Mosaic is a network of 36 local agencies in 10 states, and national supports are provided out of Omaha. And we have a 30-year partnership with CQL, and I'm pleased that Carly will be able to present some information about Mosaic's work with CQL. The perspective that I'm sharing today really has to do with Mosaic's experience with the introduction of managed care in Iowa and Kansas, and we have a long history of offering services in Arizona as well. In addition, we've been listening and learning as a provider because we believe that we will have expanded managed long-term services and supports, and we must be prepared to operate in that universe. Next slide. So oftentimes I feel like I'm living in a parallel universe, and I'm assuming I'm not alone. On one hand, we have the concentration that we need to have on people. As we work to provide person-centered services, we're serving people with more and more complex needs. We want to meet and exceed regulatory standards. We've got the workforce challenges, especially around direct support staff, and continuing to offer opportunities and choices to folks who've chosen us as a service provider. And then on the other hand, I feel like I have people talking in my ear saying, you need to be more efficient, you need to do more with less. Rate increases are few and far between. Being told that we have to adopt a healthcare mindset and leverage technology and use data. And we're learning new technologies, or a new terminology, like a PMPM, per member per month, or revenue cycle management. And sometimes I think, okay, which voice am I supposed to be listening to? But in reality, it's both. I believe we're facing the most significant transformation that we've seen in the IDD service sector since the introduction of the HCBS waiver. So really more than 40 years, we have not had change of this magnitude. But we know we have to remain focused on people, and we also have to acknowledge that how we operate as providers is changing due to changes that are happening in the healthcare landscape. Kathy alluded to some things that make IDD services unique when we think about MCOs. But here's a list of things that I think it's really important for us to understand. First of all, most folks with IDD have lifelong services. So these are not services that occur maybe at the end of someone's life, such as senior services, but they happen throughout someone's life. It's not episodic. And the needs of a person change over their lifetime. Most of us are very reliant on Medicaid. We have very little private pay. Oftentimes we talk about ourselves as a price taker versus a price setter. We don't control the rates that we're provided to deliver services. We certainly simply accept the rates that are offered to us by states and counties. We offer a vast array of services, but we always focus on providing personalized services. Folks have complex needs. Maybe they have behavioral health needs and physical health needs in addition to their intellectual developmental disability. And then lastly, we have several things that I call civil rights implications, but it's things like ADA and Olmstead and the final rule that really make us unique because we fought long and hard to have community-based services for people. And we want to make sure that during this transition to expanded managed care, we're not losing those things that have been fought for so long. I really encourage providers to think about some specific steps that need to happen as we help educate managed care organizations and states about the potential impact of expanded managed care, given the unique things that exist with our IDD service delivery system. So I have 4 things here. One is to educate and make sure that people understand not only the difference between Medicaid and Medicare, which seems to still be a challenge for some folks, but to understand the difference between Medicaid that provides for physical health insurance coverage and the Medicaid that provides for IDD services. The second is to inform people, and don't assume that people who are working on expanding managed long-term services and supports understand the facts that do make IDD services so different. Third, to advocate. What we've heard from managed care entities is to make sure that we're not only sharing the data about the services that we provide, but making sure that we're offering stories that show the impact of our services. And then lastly, I think we need to influence. That one of the greatest aspects of implementation of managed long-term care has to do with planning and making sure that people understand how important it is that we enter a managed care environment with a careful and well thought through plan. So what we know is perspective matters. As we think about who determines value, you think about people with disabilities, families, and payers and regulators and community members, and everyone has a different perspective about what value means. So think about a person with a disability who has a personal goal to receive employment and wants to earn an income and have relationships and connections that are outside of the place where they live, outside the disability community. What they would value might be very different than a family whose focus is primarily on safety and security. Then sometimes payers or regulators are focused on efficiency, serving more people with the same or less resources, the accountability for results, and making sure bad things don't happen to people. And then right now in our communities, I think we have a pretty divisive lens when we think about what people should pay for in terms of Medicaid coverage and healthcare services. And so it's one of the biggest things I think we're wrestling with is who is going to be the voice that says, these are the services we value and this defines quality. In my experience, perspective matters. It's where you sit in the process that informs the way you think and act and plan for the expansion of managed care. So a little bit about Mosaic's experience, and this is a picture of a ship in rough waters. And I would say that this is what tends to happen in the beginning when managed care is implemented at the state level, and the trick is to be a part of the conversation until the waters settle down. Oftentimes, NCOs come into a state and they're hiring state experts, some of the staff that we know and work with and we trust, and they understand the system are now going to work for the MCOs, leaving the state with a shortage of expertise and knowledge and experience. We also have seen quick launches of managed care with high expectations but unclear roles, and it's not often clear about how decisions are made. We all know, and managed care organizations and states alike will tell us that careful planning before the launch of expanded managed care is critical. There's uncertainty, there's confusion, and oftentimes, and we've seen this in both the recent examples of expanded managed care, is there are unique business pressures that evolve. Payments often slow down, and so you have to be prepared for that. The state wants to engage and needs to engage in conversations with providers, as do MCOs, but it has been rough sailing in the beginning and things smooth out over time. So I think there's 7 things that providers can do to be prepared for expanded managed care. And the first 2, I think, are things that we're already really good at. It seems to be the new lingo in healthcare today that people are talking about serving the whole person and looking at a person's physical, mental, and social needs. But those are things that we've already been focused on. If you've been working with CQL and been working with personal outcome measures and basic assurances, it's nothing new to think about someone's overall well-being and their goals and hopes and dreams for all aspects of their life. But we have to make sure that we're really thinking about the physical health of someone, and we're beginning to look at things like emergency room visits or hospital readmissions, behavior supports or a behavioral crisis, medication management, some of those things that haven't been top of mind for us, thinking, no, that's traditional health care. Now with a whole person mindset, that's something that we as IDD providers also need to be tuned into. The second bullet, again, is something I think we do a good job with, but we have to know who our customers are and we respond to their needs. And we need to help them articulate and advocate for themselves about what their needs might be and what their hopes and dreams are for their future. And remain committed to personalized services and not treating people as a number, but treating people as people who have outcomes that they want to see in their life, and we're walking that journey with them. The third thing that I think providers can do is know your payer. And this is one of the best pieces of advice that we've gotten about the evolving managed care landscape. When you engage with a managed care organization, they're going to present you with a contract. And that contract is what they hold you accountable to provide. But in addition, you need to have a conversation with these MCOs to see what are your pain points? What do you need? What are your aspirations? What are the gaps in services that you're seeing? And how can we as providers help step in and alleviate some of that pain while strengthening our own organizations? So I have three pieces that fit underneath that. I think it's really important that providers are at the table when the conversation is happening. Again, providing managed care in an IDD landscape is very different than providing managed care in the physical health or behavioral health or senior services arena. So once the decision has been made by a state to move into a managed care arena, get to the table, educate, inform, and advocate. Be solution-oriented. I really like Kathy's last slide when she said, why would we sit at the table and argue for the status quo when so many of us have been pushing for years to change the system that supports people, to be more person-centered, to be more realistic, so that supports ebb and flow throughout a person's lifetime. But being solution-oriented versus continually fighting and saying, no, we're not going to do managed care, isn't going to work. You have to be solution-oriented. Here's some ideas, here's some options, here's what we're thinking, can we partner together? And then last but least, make sure that as a provider, you're also holding the MCO accountable to fulfill their end of the bargain as we have a conversation about managed care and serving people. Also, as a provider, I think it's important internally that we focus on these four things. We need to realize that this will be the biggest change that's happened in our field in more than 40 years. We're seeing rapid consolidation, some big market changes. We now find ourselves in contract negotiations with large insurance companies, where in the past maybe we negotiated with a county or a region or a state. Things become more complex, and this will become our reality. How can you learn and grow from acute healthcare, physical healthcare, behavioral healthcare, find other partners who've been through this transition and learn lessons from them? Secondly is really align your culture with the new normal. What you'll see and what we hear from managed care experiences is a much deeper orientation to results and measurable results. We tend to like to tell stories and give examples of impact, but along with that, you do have to have the data to back up and show the positive impacts of our services. The other piece of that, I think, is really acknowledging that we are healthcare providers. And many times we've said that's not our role, but it is in the new normal as we think about managed care and whole person healthcare. Thirdly, then, we need to develop capacity, and we have to learn to balance more of a business mindset with a service mindset. That's around leadership that can manage and lead change. Technology, typically in the IDD field, we're slow adopters of technology, but I heard an MCO say about a year ago that they have transformed themselves from being just an insurance company to being a data company. They have a lot of data and a lot of information, and we need to have the technology to move into that space. Back office supports as we're looking at adhering to contracts and billing in new and different ways. Cash management as we see payments slow down. And then last but not least, this contract negotiation and management. We need to know what we're being held accountable to provide and what the MCO is accountable for as well. And the last bullet I'm going to throw in there again to talk about, and maybe even like, data, that it certainly is becoming an increasingly important aspect, that as we define what's quality, what's value, can we measure that, and can we show the positive impact of our services in the lives of those who've chosen us to be a service provider, and that's really important. In the end, though, next slide, I want to make sure that we all know that we have to remain focused on people. Is this a transition? Yes, it is. But remaining focused on the folks we serve is of paramount importance, and remaining person-centered in the midst of this evolution is essential to our success. So I'd like to now turn this over to Carly Friedman, who's going to share some valuable information.
Thank you, Linda. Now let's look at quality and value-based services. What does the data tell us? But first, before we get into the data, I want to briefly mention the basic assurances as they play an important part in this analysis that I'm going to describe. Because of time limitations, I'm going to rush over them now, essentially reminding you that the basic assurances is an organizational assessment that ensures health, safety, and human security of human service organizations. The basic assurances are comprised of 10 factors, ranging from rights protection to staff resources. Within each of these factors, there are 92 indicators that cover a wide range of topics, and you'll see a number of them today. In October 2018, CQL, the Institute on Public Policy, and Mosaic organized a symposium with approximately 25 thought leaders in the healthcare and LTSS industry. The stakeholders represented service providers, industry associations, managed care organizations, and other key leaders. The symposium was designed to develop a common understanding of value-based quality measures for people with IDD to ensure that as the industry moves to managed care, the quality metrics utilized are meaningful for people with IDD. This presentation is a summary of those findings that is a roadmap for the key measures which would support people with IDD to receive high-quality services and supports. Our quantitative analysis was comprised of data from 28 Mosaic agencies who supported a total of approximately 3,000 people. The data was from a 3-year period, fiscal year 2016 to 2018. We looked at a number of traditional health metrics, including hospitalization data, which was every visit to the hospital, regardless of if they were admitted or not, appointments, which included any type of medical appointment, ranging from family medicine to specialists. This also included psychiatric appointments as well. Medication errors, which included documentation of every time there was a medication error, regardless of the reason. Injuries documented any type of injury event, for example, redness, bruising, bleeding, lesions, and so on. Behavioral issues, which marked all behavioral events or issues people had. We also controlled for agency size, that is the number of people the agency supported. Because of collinearity, I actually built the controls right into the dependent variables for agency size, resulting in all the variables becoming rates. So when I say rate, I mean the number of events for every one person the agency supports. For example, the hospitalization rate is the number of hospital visits for every one person the agency supports. So if I say the hospitalization rate was 1.5 for every one person supported, for an agency that supported 100 people, there would be 150 hospitalizations. So now that we've got that out of the way, let's look at some of the findings. Findings revealed when organizations respect people's concerns and responded accordingly, agencies had significantly lower hospitalization rates. When they did so, they had a hospitalization rate of 1.03 for every one person they supported in the 3-year period versus 2.57 for when they did not respect people's concerns. Again, this is controlling for the size of the agency. So if you think about an example of an organization that supports 500 people, hospitalizations would be projected to drop from 1,285 in a 3-year period to 515 when organizations respected people's concerns. That's a huge difference. Respect was actually a common theme across these analyses. Here's another finding on the right. When services and supports are in place to enhance dignity and respect, agencies also have significantly lower hospitalization rates. When organizations put systems in place to ensure people had meaningful work activity choices, that is, they had a meaningful day, hospitalization rates were significantly lower at 0.65 per person supported in the 3-year period versus 1.74 per person supported. Natural supports also resulted in lower hospitalization rates. When organizations had policies and practices to facilitate the continuity of natural support systems, there were almost 2/3 fewer hospitalizations. Moreover, when organizations facilitated each person's desire for natural supports, there were also significantly smaller hospitalization rates. When organizations had individualized emergency plans in place, the hospitalization rate was 1.03 in the 3-year period, compared to 2.35 when they didn't have individualized emergency plans in place. When organizations treated people with psychoactive medications for mental health needs consistent with national standards of care, hospitalization rates were lower. Moreover, when systems and practices were in place to ensure people were free from unnecessary intrusive interventions, people were hospitalized significantly less often. As I've mentioned, although I've been describing individual indicators for the basic assurances, we also looked at the total number of indicators present and how that impacted things. While there wasn't a significant relationship with total hospitalizations, there was when you pulled out just those hospital visits that did not need actual admission, which is where those unnecessary trips to the hospital are likely to fall. So there was a significant relationship with the total number of basic assurances indicators present and hospital visits without admission. For example, an organization that had 20% of the 92 indicators present is expected to have a hospitalization without admission rate of 2.8 for every one person they support in a 3-year period, whereas an agency that has 100% of the 92 indicators present is expected to have a rate of 0.5 for every one person they support. For example, if both of those agencies supported 500 people, the one that scored 20% of basic assurances would have 1,400 hospital visits in the 3-year period that did not result in admission, whereas the one that scored 100% would only have 250 hospital visits that did not result in admission, which is a huge difference, especially if you think about expenditures. Medication errors is a big issue. However, we found when organizations respected people's concerns and responded accordingly, there were significantly fewer medication errors. Similarly, when organizations had systems in place to ensure supports and services enhanced dignity and respect, there were significantly fewer medication errors. When they did this, they had a medication error rate of 3.13 per person supported within a 3-year period, whereas when they did not, the medication error rate was 9.3 per person supported. Other factors that reduced medication errors, when organizations treated people with psychoactive medications for mental health needs consistent with national standards of practice, there were fewer medication errors. When they treated them consistent with national standards of practice, there were 3.13 medication errors for every one person they supported in the 3 years, versus when they did not, there were 14.92 for every one person they supported. Also, when people were free from unnecessary intrusive interventions, there were fewer medication errors. Another variable we looked at was injuries. Dignity and respect was a critical component again. When organizations had systems and practices in place to respect people's concerns and respond to them accordingly, the injury rate of the people they supported was significantly lower. When they did not respect people's concerns, they had a rate of 12.61 injuries in the 3-year period for every one person they supported, whereas when they did respect people's concerns, it dropped significantly to 5.85. Similarly, when services and supports enhanced dignity and respect, the injury rate dropped from 12.77 to 5.98 per person supported in the 3-year period. When systems were in place to ensure people had meaningful work and activity choices, the injury rate dropped from 9.38 in the 3-year period for every one person supported to 3.02. When organizations had systems in place to facilitate each person's desire for natural supports, the injury rate was significantly lower. For example, for an organization that serves 500 people, the number of injuries is projected to go down from 9,600 in the 3-year period to 3,100. In terms of behavioral issues, when organizations respected people's concerns and responded accordingly, the behavioral issues rate dropped from 11.07 to 2.7 per person supported in the 3-year period. Same with when people had meaningful work and activity choices. When organizations ensured people had meaningful days, there were significantly fewer behavioral issues. When organizations ensured thorough, appropriate, and prompt responses to the substantiated cases of abuse, neglect, mistreatment, and exploitation, and to other associated issues identified in the investigation, the behavioral issues rate dropped from 14.86 for every one person supported to 2.7 for every one person supported in that 3-year period. Now, most of the findings thus far have examined the different ways organizations support people with disabilities and how that impacts the health metrics. But here are some findings related to the ways that organizations treat their staff. When organizations implemented ongoing staff development programs, the behavioral issues rate amongst the people they supported dropped pretty significantly from 14.86 to 1.97 per person supported in the 3-year period. Similarly, when organizations treated their employees with dignity, respect, and fairness, the rate dropped from 11.58 to 1.97. So, for example, an organization that supports 500 people who did not treat their employees with respect is expected to have 5,800 behavioral issues within a 3-year period. Whereas if they did treat their employees with dignity and respect, the number drops to less than 1,000 behavioral issues, really indicating the way that staff are trained and treated really trickles down. When organizations had systems and practices in place to ensure people were free from unnecessary intrusive interventions, the behavioral issues rate dropped from 23.73 in the 3-year period for every one person supported to 2.7. For example, for an organization that supports 500 people, the number of behavioral issues is projected to go down from 12,000 in a 3-year period to 1,400, a tremendous difference. Now that we have a better idea of the data from what types of factors can impact quality, let's switch gears slightly and examine the findings from our focus groups with the thought leaders that I mentioned earlier. We asked the thought leaders not only what quality is, but how do we get there? Although health and safety in and of themselves do not wholly encompass quality, they were seen as foundational building blocks upon which everything else is built. Once these foundational building blocks are in place, it's important to ensure people have a meaningful life. People with IDD must be supported to reach their potential to live a life of quality. Quality necessitates a holistic approach, which includes wraparound, robust service delivery model throughout the lifespan, especially during times of transition. For quality services and supports, attention should be paid towards social measures. Often called social determinants of health, or SDOH, these social measures include these factors that contribute to health and quality of life, such as social support, access to opportunities, etc., but are beyond traditional health metrics. One of the most commonly described aspects of quality was true informed choice. It was recognized that people with IDD must not only have choices, but these choices must be based on information regarding numerous options and opportunities. Ultimately, informed choice is about control over one's life. That is about services and supports truly being person-centered. People with IDD must be supported to find their voice and become empowered. People with IDD must also be centered in their own lives and have a say in what is happening. As such, a vast array of services must be designed around the person to meet their interests and choices, rather than services and supports being limited by a set menu of services. Although person-centeredness is a cornerstone of quality, it was recognized that person-centeredness is unfortunately often still a philosophy and not a practice. Community integration was also considered a critical aspect of quality. Community is not merely a place where people with IDD go or have a presence. Rather, it's a place that people have a stake in and a place people feel they belong. Community integration is about engagement and being embedded in a community. It is a place where people have connections and meaningful social roles. Another common theme regarding the meaning of quality was ensuring people with IDD have meaningful days, including community-based employment opportunities. People must be able to choose what they do during the day, and those activities must be meaningful. Relationships were also frequently mentioned as a marker of quality services and supports, especially because people with IDD often face isolation and loneliness. Quality services and supports involve ensuring people with IDD have the relationships that are most important to them. Quality services and supports also help people with IDD build relationships beyond paid staff, including by extending into their communities. Services and supports should also facilitate creation of a network of natural supports and lifelong connections. Dignity and respect was also recognized as a vital aspect of quality. People should not only feel valued and respected, but as a part of dignity and respect, people should have control over their lives and have real and meaningful choices. If people with disabilities are truly to have equal opportunities, this includes the opportunity to take risks. The best support involves balancing duty of care and dignity of risk. Continuity and security was also described as an aspect of quality services and supports for people with IDD. The stability, tenure, and retention of DSPs is a critical component for the continuity of services. While in the current service system, some DSP turnover is likely unavoidable, quality services and supports work to ensure a lack of continuity does not result in unmet needs. Finally, attendees also believed quality involved creative uses of technology. Technology should not only be embraced for the sake of improving services and supports, but also utilized to reduce unmet needs. In addition to unearthing trends in what quality services and supports for people with IDD involved, the findings of this meeting also revealed potential ways to build quality frameworks. One of the first steps in doing so is to create quality standards. There was a recognition that across the country, states are doing different things and everyone was working from a different perspective. Often, these experiences and perspectives were siloed and not shared outside of the state or network. As such, it is recommended that best practices in Medicaid managed care not only be established, but shared across networks and systems. There must be collaboration across groups and quality bodies. It was also recommended that quality standards be based on data and measures. The key is how you measure it and consistency in how you measure. One such way that was suggested to help set baseline standards was accreditation. Accreditation ensures consistency and quality standards across service and support providers. In order to create quality standards and build better frameworks, there must be cultural change. The current service system is very much entrenched in the culture and legacy of fee-for-service medical models. Fee-for-service models pay based on the number of services provided, rather than the quality of those supports. Older models also are often risk-averse. In contrast, quality, value-based services should aim to build services around the person, not the other way around. As such, there must be a vast array of services offered and available. For this change to occur, there must be provider buy-in. Providers must not only be informed of the aims and philosophies of these changes, but they must also be invested in making them happen. This organizational transformation is necessary at every level of the organization, from the people providing direct support to organizational leadership. There can be no conversation about quality improvement without discussing cost and financing, because the two are often very intertwined. Participants recognized that there needs to be a recognition that quality person-centered services and supports for people with IDD are an investment. Quality is often in conflict with funding, however. Truly committing to creating personalized services requires a robust and adequately funded service delivery system. Now, I know I've thrown a lot of information at you in a rather short period of time, and that's, what does this all mean? While traditional measures of health are important, many other factors play a role in quality services and supports and quality of life. As indicated in the findings, respect, meaningful days, staff training, and many more social determinants have an impact on hospitalizations, injuries, medication errors, and behavioral issues. So we need to work to ensure measures of value are holistic and ensure quality measures are not only value-based, but valuable to people with IDD. Taken together, our findings imply that it may be possible to impact programmatic cost by shining the focus on factors that impact quality, such as dignity and respect and meaningful days. This analysis is the first step in bridging the existing social determinants of health and value-based payments literature with long-term services and supports quality of life work. While it's preliminary, it is unique and promising and should be pursued with vigor. If you're interested in the information shared in this presentation, or more about the larger project of which this data is encompassed, we actually released a report about it, and the link is on the screen. It's c-q-l.org/mmc report. Now we'll take questions as time permits. You can enter your questions in the chat box, or alternatively, if you want to reach out to us, you can email me at cfriedman@thecouncil.org, and I can direct your questions or comments to either myself, Kathy, or Linda. So I'll go ahead and read the first question. It says, thank you for your work on this. It is a very important topic and potentially a significant shift in the field. One challenge that has faced the field for the past 30 years is DSP staffing shortages. Under traditional fee-for-service models, we have continued to struggle ensuring adequate, qualified staffing at current reimbursement rates to promote high-quality services and support. How do you think MLTSS will help or hinder work to stabilize DSP staffing? Do you think MLTSS can provide greater flexibility through different payment models or other tools to improve recruitment, retention, or tenure for DSPs?
So this is Kathy. I'll jump in, and then I'm sure others have comments too. I agree with the nationwide crisis that organizations are facing in trying to recruit and retain direct support professionals, but also other critical staff positions. QIDPs, nurses come to mind as well. I don't know that the introduction of an alternate payment model will necessarily be a solution to that challenge. I can say that I think some, at least in some states, there is some rigidity in terms of staffing models and how people receive services. So, you know, for example, the use of different types of technology to provide supports to folks. There may be states that are more averse to considering that option. And so the introduction of a new payer who may have some different considerations could possibly open doors there. And I think also as payers other than the state kind of look across, you know, our landscape and see the challenges that we face, I think there's at least some recognition that the DSP position is probably among the least well paid kind of anywhere in the healthcare sector. And looking at demographic trends, certainly you can't avoid concluding that the shrinking labor pool, more competition for that labor pool from other industries, and that wages would have to be a consideration that any organization has to make in looking at trying to recruit and retain that position. But again, I don't think that a different payer model is a solution in and of itself, but I think, again, that's where it's incumbent upon us. Both Linda and I talked about the necessity for us as provider organizations to be a part of those conversations and assuring that folks who maybe are new to our population understand the depth and the intensity that factor has on daily provision of services.
Thanks, Kathy. Okay, the next question is, in inpatient healthcare settings, there are national HEDIS measures identified and reported. Do we have those consistent standards and thresholds in the IDD field? For example, hospitals measure medication errors by the number of patients and days.
So this is Linda. Can you hear me?
Yes.
I do think that that's one of the big conversations we had when we had our symposium, to really talk about the lack of consistent quality measures that exist. So you look at HEDIS or 5-star in the senior industry, and at this point there are no national standards. And I think that's something that we need to have a conversation about. One of the reasons that we were recommending considering things like accreditation, so that we do have some guidance in that area, but there isn't anything in the IDD space at this point.
And this is Kathy. I'll just echo Linda's comments, but also add that I think that's one of the great concerns that IDD organizations have. It's the medicalization of our services, sort of going back to where things began, and wanting to assure that those HEDIS measures, while again important for healthcare outcomes and certainly not irrelevant to our population, certainly don't define the quality of the services that we provide, and assuring that, again,
we as professionals are part of the conversation about shaping what the future might be, including what those measures of quality or value are going to be that are applied to our services.
Great. So the next question is, what data measurements are you using to measure items like agencies respecting a person's concerns? Is this just that they have policies in place? So I will take this one. All the data I showed today was based on the basic assurances, and the basic assurances is a tool that we use when we do accreditation. So it's kind of a complicated measure. It's comprised of our staff going on site and not only reviewing policies, but also practices. They determine this by interviewing different folks, having focus groups, utilizing personal outcome measures, and the basic assurances, and all that information is used to culminate and determine answers on the basic assurances. And the basic assurances has over 400 different probes. And so for topics like respect, as you mentioned, there are a number of different items that would need to be in place. And we measure not only if it's in place in their systems, so their policies, but also in practice. Because a lot of times you might have great systems, but maybe those things aren't happening in practice. So for example, some items underneath respect is, do people receive needed supports to report complaints, problems, and concerns? Are families and legally authorized representatives informed about, and do they understand the organization's complaint process? Do people receive a timely response in their complaints? Does the organization, review complaints annually? Do we have a system to determine satisfaction of supports and services? Does the organization use information about satisfaction to improve those services? Those are just a few of the examples. In the slides, there is a link to more information about those basic assurances. And as we mentioned, you'll be getting a copy of the slides within about a week. Next question. As my state moves towards managed care for IDD population, how then does what does a small provider do to get ready to measure our services and supports?
So this is Kathy. I'll start, and I think it is essential for any provider organization, regardless of size, to be looking internally. And we talked on a couple of the screens about some things that organizations can do. What's your executive level dashboard telling you every day about service delivery within your organization? What are those key indicators that you know about services that are being provided, and that you're able to tell others, including possibly new payers, when they say, well, why would we contract with you? What do you have in your arsenal ready to tell them? What defines you differently than other organizations? A lot of smaller organizations might be in areas where there aren't as many larger providers. They might be some niche providers that provide very specialized services. And those services are going to need to continue to be provided. So it's not as though the need goes away. I think a lot of organizations that are of what would consider themselves a smaller size fear that in a different payer model system, they may not be able to be competitive. They may not have contract opportunities. And I think that's where some organizations are looking at some alliances, similar to what happens in the healthcare industry. And I think, the sort of the front door of the organization, who you are and what you do, it may be that that's what you choose to focus on. There may be opportunities for collaboration with other similar sized organizations or possibly larger organizations to do some of the back office business that might be required now that you don't necessarily have expertise in, but isn't the reason that your organization was created to begin with. So I do think there remains opportunities. But I think, again, particularly if you're in a state where a decision has been made that you're going to move to an alternate payment model, to begin to try and establish relationships and have conversations with those payers as early on as possible. We sometimes hear agencies say, I don't want to talk to those payers. If you don't talk to the payers, they're not going to know who you are, and they're not going to know the value in contracting with you as a provider within their network. So, trying to be a sort of foot forward in letting people know why your organization is essential to the people that you provide services to and in the communities that you're operating within.
Yeah, this is Linda. I might also add, I would pick a few things that you think are important to measure and do it well. And have that information and begin to get that mindset of measuring and demonstrating the impact of your services. I think that's another good place to start.
Thank you. It looks like we're about out of time, so I apologize to anyone whose questions we didn't answer, but feel free to email us and we'll answer those offline. Thank you everyone for attending today. We appreciate your time. Bye.
Thank you.